Hello, everybody. Welcome to another episode of Curbside to Bedside. On this episode, we interview Andrew D. Fisher. He is a trauma aficionado and a trauma expert. He is currently a second-year medical student at Texas A&M College. He is a physician assistant in the Texas Army National Guard and was previously assigned to the 75th Ranger Regiment. You may know of him from the Facebook page, St. Fisher Church of Evidence-Based Medicine, which, as you will hear, he is not responsible for, but since his name is on it, he tries to provide some oversight. So we hope you enjoy this podcast, and here it is without further ado. Ryan and I were actually looking over your CV, so to speak, a little bit earlier, looking at all the studies and literature that your name is on, and it's pretty comprehensive. So we're very impressed. First thing that I want to know is, are you St. Fisher? Is that you?
I mean the Facebook page is about me. But I didn't do it.
I actually thought that Ryan created the Facebook page, and then he.
This is not the first time that I've been accused of this.
So I mean, I know the guys who do it, right? And I have some say so over it, since it is my name. But
since your face,
but they do everything.
Yeah.
I mean, and it's not they do it in good fun.
It's hilarious and it's good information too.
Yeah. I think in the beginning when they first started out, I was probably a little bit more of a hovering to make sure they didn't do anything that would get me in trouble. But now they do everything. They know the boundaries, and they do a great job.
All right, so I'm really interested in what some of your major current initiatives are. I know you're going through medical school, correct?
Yeah.
What other projects are you working on?
I always got a couple different things going on. There's always an interest in blood and what we can do with that, and both in the pre-hospital setting, both here in the U.S. and overseas in combat. So there's continuous kind of efforts here and there. I still have an interest in ketamine, which probably my first publication ever was about ketamine. It was a case series. So still delving in that a little bit, and both kind of just doing a little bit of observational stuff with the DoD. And what I mean by DoD is, working with a couple other docs in special operations and just kind of collecting some observational information. And let me see. Oh my goodness. I had tourniquets. I'm working on a few tourniquet things, and so that's hopefully going to go somewhere eventually, but the IRB process is difficult, and I think that probably goes wherever you're going to try to do some tourniquet stuff. It may be difficult based upon the IRB. That's kind of probably where I am right now, is just looking at whole blood and a little bit of observational ketamine stuff, and trying to maybe take a look at some tourniquet stuff.
Awesome. So you're still pretty active in research.
Yeah. I think most of my stuff is like performance improvement stuff, so the PI work, and so it's not true research. I think the only thing that maybe come close to research is maybe the tourniquet stuff I'm going to try to do here, but everything else is pretty much just looking at previous stuff. That's what, if you look at everything I've ever published, well, not everything, but most of the stuff I've published has always been like this, pulled from a database, retrospective sort of stuff, and it's overall looking at processes that are already in place, and kind of taking the data set from there and evaluating it, and see if we can then maybe change, how we practice, or maybe just kind of report on how the outcomes of some things are. So it's not really true research per se, but someday, I'd like to, as after I get through medical school, I think delving more into actual research would be fun.
I think the PI stuff is no less important, because some of the seminal changes have come about as a result of those kind of retrospective reviews. Oh yeah,
it's so difficult to do anything prospectively and and randomized in pre-hospital medicine, and when you try to do it in combat, it's even more difficult. So the majority of what we do is from combat medicine, especially pre-hospital combat medicine, is typically all PI work, and that's okay too. There are limitations based upon PI work and looking at that retrospective kind of look, but again, a lot of important changes. Like I said, a lot of important changes have come out of that, and I'm good with that right now. As my bandwidth can only do so much. So I think it's a great opportunity to really take it to improve on existing systems, and if any issues within those systems, trying to improve that.
Absolutely. I'm amazed you have the time to do anything else but medical school, because I would probably die.
I'll be honest. I think the military probably made me believe that I could do 10 different things all at once. Be honest with you, I probably don't do anything really well. I probably am. I'm doing things at the mediocre level. Yeah, there are other things I probably, looking back on my med school, maybe some things I probably wouldn't have focused so much on, and maybe focused a little bit more on maybe some of my studies. But you know how it goes. I mean, hindsight's 2020, and I'm happy with what I've been able to do, and I am learning to not do as much because my wife has been telling me for years, stop doing so much stuff. And I'm like, I'm trying. So, but it's finally sinking in, and especially as I get ready to apply for residency, that I'm letting stuff go. And because if I don't want to go in to apply for residency and then go, you have 20 things that you say you're going to be doing during residency, and that's not going to fly. So
that's a red flag.
So I'm trying to let those things go and just focus on the very critical stuff. Like I think the Committee on Tactical Combat Casualty Care is one of those areas where I'd like to stay involved.
Yeah, and I would definitely like to see your involvement stay there as well, because you guys put out some awesome stuff. We've kind of been fascinated with acute traumatic coagulopathy, and could you elucidate onto the mechanism of it, or just kind of break it down at a semi-basic level for some of our listeners who may not have heard of it before?
So these are my own opinions and do not represent anything from the DoD or a university or the Texas Army National Guard or the Committee on Tactical Combat Casualty Care.
Understood.
There's two different concepts. One is traumatic-induced coagulopathy, which can happen at any time during after a traumatic event and hemorrhage. And then there's acute traumatic coagulopathy, which happens within a certain time frame after your injury. You get a couple different issues that pop up. Typically, if you look about how we've treated trauma, we were kind of the big cause of a lot of this acute traumatic coagulopathy. Because we were pushing things like crystalloids or things like Hexten, and we're pushing these things at room temperature. These cold, acidic fluids that diluted our blood, or our trauma patient's blood out, and so you created the coagulopathy through just simply diluting it out, right? So I mean, if I give you some salt water and put it into your veins, it's eventually just going to create that dilution. Second, like I said, it's cold. Hardly anyone is ever giving fluids at like body temperature or slightly above body temperature. It's always, about 70 degrees or something like that.
It's off the shelf, out of the bag.
Right. So maybe I'll put it on the. I remember back when I was a paramedic. Yeah, you put it on the dashboard, right? How well that really worked. And then you get those fluids like normal saline, which are pretty acidic, that can cause the acidemia. So we kind of help push that along. Now there are other things that go along with the idea of acute traumatic coagulopathy, and this is a lot of debate about what actually causes it, and I don't know if we actually truly know the exact cause. But I'll say that overall, when we start bleeding out, we get we get the, decreased cardiac output. We have the poor tissue perfusion. We develop this oxygen debt. We already talked about acidosis, but you start having issues with maybe breaking down clots too fast or not breaking down clots fast enough. And that is an issue. Even if you are bleeding and you have these building clots in your body is still actively, going through this physiologic fibrinolysis, where it's breaking down clots and kind of help building them back up and stuff. You get a little bit of platelet dysfunction too. And I think part of the issue is we don't really consider blood an organ. And I think that's contributes to our lack of understanding of why coagulopathy is such an issue. So if we think about blood as an organ and needing to restore the functionality to that organ may help understand why giving blood when you bleed out is important, and why giving things like crystalloids could be detrimental, because that doesn't do anything to really help out returning that functionality of blood to normal. A lot of people think that, like I said, fibrinolysis is kind of the big issue, and that has to do with probably a lot of TPA and plasmin activation, and that's why they think maybe TXA will help. Well, if we can stop TPA from activating plasminogen to plasmin, then maybe we can stop some of this breakdown of clots. I think that is important, but I also think it's important that you should be resuscitating with blood products while you're doing that. And without that, I don't know if we're going to get a significant impact on with TXA in our trauma patients. Some people think that thrombin is the issue, right? So you see in some studies demonstrating that prothrombin, part of the clotting cascade drops during these periods of hemorrhagic shock. Is it part of that? That's the issue. And other people think it's something called protein C or activated protein C.
So that's what I've seen the most of.
I think Glenn Brohe did some work in that area.
Yeah, and I used to think it was probably activated protein C based upon what I've read, but I really, looking now, I think it's probably not clear enough. It probably plays a role. I think it absolutely plays a role, but I don't think it's the primary driver. I think I'm probably more leaning towards, a fibrinogen problem more than anything.
But clinically speaking, I think it's relevant that if we don't fully understand the patho, it is relevant that a lot of it is iatrogenic, caused by us, correct?
Absolutely. I mean, not only are we giving bad fluids, but then we're not warming up our patients. I mean, how many people actively try to rewarm their patients? Hypothermia is a significant issue that needs to be addressed in our patients.
And you can cause, and I was kind of surprised to learn this, that even just giving a lot of packed red cells can cause resuscitation associated with coagulopathy.
Yeah, I think, if you're doing that old traditional resuscitation, and this is, you look in the Pamper Trial, this is what they did. They resuscitated with a little bit of crystalloid, and they did with PRBCs. And I always go back to say, well, the way I think about it is I can give all the blood cells, I can oxygenate them, all these RBCs, all I want, but if we're not stopping the bleeding, then how does that really help us out in the long run? So I think, well, if we got to stop bleeding, we're going to need platelets, or we're going to need and maybe plasma. Either or would be great, but plasma is really probably where we need to start, and that obviously has most of the clotting stuff that we need. Is that the way forward instead of just PRBCs? And I think it's a balance, right? So I think if we're going to do PRBCs and plasma, I think that's great. But just giving PRBCs, I mean, you are pushing a lot of crystalloid, you're pushing a lot of anticoagulants that's in the blood product, and also the additives that are in the blood product too, that kind of help contribute to that.
And I've seen a decent amount of evidence for taking a plasma first approach, especially from Hal Moore and his folks out of Denver, basically saying that it's a balanced resuscitation fluid. So it's not only does it contain all the coagulation factors that we're looking for, but the appropriate amounts of essentially physiologic anticoagulation factors. So the theory being that it kind of helps balance out some of those fibrinolysis into antifibrinolytic activities that have been seen. Either the helps balance out or helps assist in correcting the hyperfibrinolysis, or the more supposedly more common fibrinolytic shutdown.
Yeah, and I believe that. I find it odd that they didn't really see a difference, though, in their combat trial.
I think that's a function of probably the transport time and the fact that they're using thawed plasma versus liquid.
I think it may had to do with the fact that I think they were waiting until the patients really were in shock before they were doing much intervention. But I don't know if it's transport time or not. It may have been, and it maybe have to do with the plasma that they were using. But I certainly think it's, I don't think you should be waiting for your patients to go in shock before we start treating them.
Absolutely, because the Pamper trial showed, was it the Pamper trial? The Air Medical one. Showed benefit. The proper trial. Showed benefit with pre-hospital plasma first, mortality.
Well, that's the Pamper trial out of Pittsburgh. That was just released. Yeah, that was traditional resuscitation with crystalloid and RBC versus plasma, and then they would throw on some RBCs too. There's actually a second look at that came out recently that was pretty good, and that showed that if you give plasma with RBCs, shocker, you're going to have higher survivability.
It's almost like it's nearly physiologic.
Yeah, right. But yeah, I mean, it's a shame that we've known this for so many years, but it's just taken us this long to kind of relearn all these lessons.
So whole blood makes physiological sense, but is there much evidence saying that whole blood is better than 1-to-1 with RBCs and plasma, or 1-to-1-to-1?
If you're looking at fresh whole blood, certainly. If you look at the stuff in the early years of Iraq and Afghanistan, you saw people like Phil Spinella, Murdoch, and Nesson were two others. So there's been a few studies out there that kind of show that fresh whole blood is vastly superior to component therapy. Now, we don't really have anything to compare yet. I don't think we have any really strong data to compare, cold stored whole blood to component 1-to-1-to-1 therapy. I know there's efforts out there currently, and there is data that's been generated, but I don't know if we have anything substantial that demonstrated that yet.
My next question was going to be over. Just going to go back to trauma coagulopathy, and going through the literature, there seems to be 3 different types of phenotypes associated with trauma coagulopathy. And a lot of this came, again, from Denver and Hal Moore's group with fibrinolytic shutdown, which is something you hear about a lot, especially when in the context of the TXA debate, physiologic, and then hyperfibrinolysis, which is where TXA is supposed to lie in the most benefit. Now, from the things that I've read, and I could be interpreting this completely wrong, is that the majority of patients have a fibrinolytic shutdown phenotype. That is the most commonly presented, at least by some of the data that has been put out so far. And their death is predominantly due to organ failure later on the resuscitative course. And with them being insensitive to TPA, I guess the thought being if you give them TXA, they'll have an increase in VTEs and so on. Basically, the gist I got out of it was that the fibrinolytic shutdown is the most common, but not the most exigent to treat. The hyperfibrinolytic is the most moribund, essentially, but it's also probably the least common of the findings, which listening to honestly, just listening to the East podcast and some of those other guys talk who are a hell of a lot smarter than me are basically we should probably give those people. And I thought it was fascinating how it was tied, or the theory is that it's tied to 2 different injury patterns, with the hyperfibrinolysis kind of arm being more associated with a purely ischemic or hemorrhagic insult, and the fibrinolytic shutdown, which is more common in civilian trauma, being associated with gross tissue disruption. If you'd care to elucidate on that, because honestly, that kind of blows my mind.
Yeah. So I had probably a year ago now, I touched on this somewhere on social media, talking about these different shutdown are these different fibrinolytic types, and people are like, I don't know what you're talking about. I'm like, I'm serious. I said, in 2014, I was at my first remote damage control resuscitation symposium, and I heard Dr. Moore talking about these different fibrinolytic types and how TXA may not be the best thing to give in the pre-hospital setting until you can maybe get them to a trauma center and evaluate them. And I was, before then, I was like, TXA, just give it to everyone. But I certainly think there's something to be said for the data that's been presented, that potentially, because of the numbers of the shutdown types, that if we give TXA to everyone, no matter what, within 3 hours, yes, we could be increasing mortality. And I think based upon the time of injury and the shutdown types, that if you give it early enough, if you give it really early after the initial insult or injury, then I don't know if we'll have such a significant issue with the mortality that potentially may be associated with this. So I don't want to say that absolutely if you give TXA to someone who's in shutdown that it's going to cause them harm. I don't know if we can necessarily say that absolutely, but I think there is concern.
Yeah, I think it's founded, but I think it's also mitigated at least a little bit by the fact that a lot of trauma patients have post-trauma VTE prophylaxis, just because of that 24 to 48 hour hypercoagulability that tends to follow injury patterns. One of the things I thought was cool was the fact that the hyperfibrinolytic theory and the more stringent or at least targeted TXA administration was actually kind of confirmed in the CRASH 2, or at least supported by the CRASH 2 study, where the subgroup of patients with the systolic blood pressure of less than 75 actually received the most benefit from TXA. I think the overall risk reduction was 1.5%, but the profoundly hypotensive is like 2.2 or something like that. Absolute risk reduction of mortality. And then some of the data Floyd and I was looking at, whereas in non-traumatic cardiac arrest, the blood drawn from those patients just shows a high degree of hyperfibrinolysis.
Yeah, I think it's interesting that you do see a higher mortality with the hyperfibrinolysis, and maybe that the TXA can make an impact on that. The physiologic, I think I don't think it really matters if you give TXA as long as you give it within 3 hours. It could be helpful, but the shutdown, I think we probably need to give it pretty early on. If we don't, I think if there's an association with mortality, then you probably need to give it earlier rather than late.
And I'd agree. I think that if you're going to get it from a pre-hospital system, it's probably going to be at least civilian side, it's probably going to be closer to the time of injury, the true time of injury.
I hope so. And I something else that I just talk about all the time is this isn't about what time can you get to the hospital, or how long can you get to the patient, or how long you're on scene. It's when was the patient injured, and that's the most important aspect. Somebody goes, well, we'll just bring him to the hospital. Well, okay, so it's going to take me a few minutes to get him to the ambulance, and then we're going to kind of mess around a little bit, and then we're going to get them there, and then we're going to take a few more minutes to get them out, and then we're going to take them to the hospital, to the trauma room, and all that time adds up. When was the patient injured? And that's why I think taking the state-of-art medicine to the patient in EMS is critical versus just putting them in an ambulance and taking them to the hospital.
Absolutely. And where I work full-time, it's maybe, depending on traffic, it's probably about a 35 to 40 minute straight drive time. But that neglects things like time on scene. Where were you at in the county? Did you have to stop? Was there an issue getting the patient? Most of our traumas are MVC, so was there an issue with extrication? So frequently, we're looking at an hour 15 plus from the actual time of injury.
Okay, so for our listeners, you guys really just nerded out.
Yes.
Confused me a little bit. So we've got some patients that are hyperfibrinolytic and some that may have complete fibrinolytic shutdown, and TXA could be deleterious in that population. Now, with that being said, do you think that we should continue to argue for widespread utilization of TXA in the pre-hospital environment, or should we take a pause and see if better data comes out?
I think if you can give TXA within 30 minutes of injury, I think that's probably fine. Again, I don't have a lot of strong data to support that, but I think the earlier you give it, the safer it is going to be for those who may be at risk of being a fibrinolytic shutdown patient.
Is there a physiologic basis for that?
I don't know. I'm just trying to think that with a shutdown, is the onset, is it sooner rather than later? My understanding is that these shutdown patients tend to die a little bit later, and is that because the shutdown onset is a little bit later, or is it I don't know, or why do they die a little bit later in the spectrum versus others? And so if I give it early enough, does that really impact it? Because you're supposed to redose it, right? So, I don't know if you give it early and then you don't redose it, or if you give it early and then you kind of you take a look on TEG or ROTEM, which neither really are great evaluators of acute traumatic coagulopathy and how TXA impacts it. So there is a limitation in that aspect of these studies, is that we really don't have a great tool to evaluate acute traumatic coagulopathy based upon blood samples.
It's at least better than PT or PTT and INR.
Yeah, it is. I think so.
And
there was that Brohe study that saying that like fibrinolytic activation, and this is the conclusion, occurs in the majority of trauma patient, and the magnitude of fibrinolytic activation correlates with poor clinical outcome. And they said that it was not detected by conventional TEM or TEG in the U.S. And so I guess it's not a sensitive measure of actually the patient's amount of fibrinolysis. So I don't know much about TEG, but I read that article and it seems to support my bias for TXA, so I'm going to go with it.
So I'm biased towards TXA more than I'm biased against it. And reading through some of the stuff about fibrinolytic shutdown, I was initially we at a part-time place I work, we ended up getting TXA, but one of the local trauma surgeons that was on the approval committee kind of really narrowed down the selection criteria. So you kind of had to be the sickest of the sick to get it. And going through and reading it and rereading the evidence, I can actually appreciate a lot. Then I went, since I've gone back and kind of read the base literature, him being more selective makes more sense. I don't necessarily agree with it entirely, but I think that if you're going to give TXA to the purely fibrinolytic patient, I think the reduced end-tidal CO2, the profound hypotension, the suspicion for ongoing hemorrhage makes sense. But then again, to your point, I think the earlier you give it, so within that 30-minute window, they're probably going to be okay in terms of VTEs, or even if they develop fibrinolytic shutdown later on down the line.
Well, if you read the article I referenced earlier from the one that Hunter Moore was the lead on, in conclusions, they say the pathologic extremes of this coagulation process predict the cause and timing of mortality, which can be assessed within 60 minutes of the patient's initial blood draw using TEG. I think there is some timing issue that has to do with when this initially starts to be a problem.
It's the same thing with platelets too. They're still trying to figure out precisely when you should give platelets during the resuscitation.
And so if you look at whole blood, a lot of like the whole blood stuff, you kind of start to lose your platelets after about 14 days. So I'm sure a lot of the blood that whole blood we're giving out there probably doesn't have a much platelet function. But I do believe probably platelets should be given rather quickly in the process. Obviously I think start with plasma. You can get some RBCs, but maybe are platelets the last thing to go on a 1-to-1-to-1? They probably should be. But you do obviously get some platelet dysfunction too within these trauma patients. So it is important to address it. At least we're getting away from pushing crystalloids and then just RBCs.
Is it better to give cold blood than no blood, in your opinion? I don't know if there's any evidence out there for that, but
I saw something recent, and I can't necessarily point to which study it was, but something along the lines of giving a lot of cold blood.
I think giving any large amount of cold fluid to a patient is probably terrible.
I saw something somewhere that said, again, I wish I had these studies pulled up. But you could probably give like 1 unit of cold blood and probably not be bad. Bad stuff happen. But I think any more than that, I think you're asking for trouble. It's cold blood is, you pick it up, it's like, wow, that stuff is cold. I can't imagine putting that to my body right now. I think trying to talk yourself into giving cold blood is probably not a great idea.
Just to be giving it, or say just to be able to say you give blood. Right.
And there are so many great blood warmers out there now. And if you are carrying blood and don't have a blood warmer, then you've done something
I would agree
wrong.
with that statement entirely, but it's so expensive. It's not really that expensive to get an inflow.
I don't see how people can rationalize in their head that it's okay for me to go ahead as long as I'm giving blood. I'm doing this is the right thing to do. Well, no, it's not the right thing to do because that's not complete patient care. Doing what's right for the patient involves making decisions that are truly right for the patient and not because you think what you feel is the right thing. And that often I think happens as we try to navigate, patient care with these critical patients that you really want to do something. And you end up sometimes maybe doing the wrong thing, which is why I think a lot of people do, like they just don't push pasta water on patients, right? So getting paramedics to understand, and even combat medics to understand that just because your patient has a blood pressure of 80 doesn't mean you have to push fluids on them right now. Yeah, and I think we often get in this mindset of I've got to do something. I've got this critical patient. I got to be able to do something for them. But if you don't have the right tools, is doing the wrong thing or potentially harmful thing? Is that really the right thing to do?
I once heard a physician say, "Don't just do something. Stand there." And the wisdom of that has become progressively more and more, just kind of fallen into place for me.
It is very difficult to fight the urge to do that. I mean, I've taken care of patients at the point of injury and just kind of, I think I only gave Hexton like twice and all the patients I took care of. And thank goodness I didn't feel obligated to do that to too many people.
Can you summarize or just tell us how you think hypotensive trauma patients should be resuscitated? Let's say you have whole blood, you have no blood, and then you just have plasma platelets and packed cells. Like, what would be your general approach, your triggers for administering fluid or blood?
I think first off, we kind of have to approach it from a injury pattern standpoint. So if your patient has, more than one amputation, and that's, above the wrist or above the ankle. So if I have, something below or above knee, below or above elbow, more than one of those, anything in the box, any sort of junctional hemorrhage, and pelvic fracture, those are the injuries that kind of get you started down the pathway. Vital signs, I think if you look at the data, it says that patients that have a blood pressure less than 90 tend to have a higher mortality. So as my patient has a blood pressure less than 100 systolic and has a heart rate greater than 100, and if I have lactate, greater than maybe 4, or if they, there are other monitors, different sort of monitors out there that you can use too that kind of determine different stages of injury and shock. But those kind of what I'm used to, lactate, heart rate, and systolic blood pressure. Though if I have patients that meet that criteria of less than 100 systolic, greater than 100 heart rate, and a lactate, greater than 4, then I'm going to start down that pathway with blood. That's my goal, is to get it greater than 100 systolic and a heart rate less than 100, and that's using whole blood. And I will continue doing that until I get that sort of physiologic response. Lactate is obviously, you guys know, a more trending vital sign. So as I get initial one, and as I resuscitate on down the line, if I can see it trending downward, I know I'm heading in the right direction. If not, then maybe I need to continue my resuscitation. Urine output is another good tool to use. So just as long as I'm getting, greater than half cc per kilogram per hour, I'm pretty happy with that. And that's whole blood. If I don't have whole blood, say if I only have plasma, I think I'm going to try to keep it below 100 on the systolic blood pressure, but I'm going to keep it above 90. I don't think resuscitating to 90 is a great tool. I think we need to kind of push it above that and get as close to 100 as we can. There's another study by Eastridge and some of his colleagues that demonstrated that mortality was associated with blood pressure is below 100. So is that really, actually I think it was 110. So it is, should our new goal be to hit a blood pressure above 100? And that's kind of like where we drew most of our conclusions whenever we're kind of developing this idea that we should go to above 100 for treating people. If I don't have blood, let's say if I don't have blood, so there's that thing that Karen Brohe kind of put out on his Twitter rant.
Yeah, that's kind of where we were going with this. Was what are you going to make of the Kareem Brohe rant? Because that was pretty damn epic.
So it was posted on.
It's Twitter.
Yeah, Twitter, and then it was posted on Facebook, and I agree with him that if you don't have blood products and you have to rely on crystalloids, then maybe that blood pressure should drop to about 70. And it gets up to like 70. I'm like, okay, maybe I'll need to start pushing some stuff. I don't think we really need to rush to start resuscitating people that have a systolic blood pressure of 80 with crystalloids. You work. I think you do your best to control the hemorrhage as much as possible, and I think that's probably where sometimes we don't focus our efforts. Historically, we haven't. Is to aggressively try to stop the hemorrhage. Obviously, you can't do much about non-compressible torso hemorrhage, but anything in the extremities, anything in the junctional, anything in the pelvis, you should be able to control. And you work on that, and you kind of watch those vital signs pretty closely. But yeah, I'm not going to try to resuscitate someone with a blood pressure of 80 with crystalloid.
I'd absolutely agree with your assertion there. I think a lot of at least civilian EMS providers fail to realize exactly how many tools are in their toolbox to gain mechanical control of hemorrhage. But administering fluids is easier, and it's also easier to chase a number. And part of that's just, kind of what you've been taught traditionally throughout, the course of EMS. It used to be like during my father's time, just dump crystalloid on them until they bleed clear.
Yeah.
But now we have all sorts of commercial devices for the control of, pelvic fractures and associated hemorrhage. We have at least 2 common commercial tourniquets that have stood the test of years and years of sustained war, and then wound packing and junctional tourniquets and what have you. Mm-hmm. So for most of our blunt trauma injuries, which is what the majority of civilian EMS providers are going to see, we have the ability to reduce fractures or at least stabilize them.
Yeah.
And then place tourniquets on mangled extremities. And that's probably going to be the most of what we can actually treat, unless you get that classic aortic rupture. But they probably won't be alive by the time you get there.
Do you think that an abdominal tourniquet is the equivalent to Reboa?
Are you guys? So that article's that advertisement, I should say, has popped up. I think 3rd or 4th time now on social media. No, I do not think it's the equivalent. If there's a study by Cantle that came out, I think last year, and that was done in patients who were undergoing laparotomy. And and I'll tell you right now what the numbers are. So the single center looked at patients who received trauma laparotomy over a 2-year period. And what they found was of the 9,608 patients that were admitted, 402 patients had emergent trauma laparotomy. Reboa was potentially beneficial for 96% of the patients. You want to take a guess about the AJT?
20?
9%.
Because the injuries were too high,
right,
maybe?
Right. So unless you have a zone 3 injury, right? So unless it's a pelvic fracture or something in the lower extremities, or whatever in your axilla, then using a AJT to try to control hemorrhage may make it worse. So if I have bleeding in the gut, or I could potentially make it worse, and it's not equivalent. There are certainly issues that go along with it, just like Reboa. Reboa is not benign. is definitely something to be approached very carefully and very and have some skepticism about how to implement it and what patients meet criteria for it. But I think it's a better option than the AHAT when it comes to controlling non-compressible torsal hemorrhage.
Yeah, I thought it was kind of comical just on its face that someone was trying to argue that what's essentially an exterior band was better than an endovascular intervention.
Yeah.
It just kind of didn't make sense in my mind. I'm not a smart man by any means. I was like,
oh yeah, never mind. I just kind of take other people's ideas and make myself sound smart. But it doesn't take much, much of a genius to recognize that external compression may be associated with some significant issues, and certainly I get concerned about can these people even breathe on their own very well for an extended period of time with an AHAT, on their abdomen. I don't know.
But yeah, I think that, and I've seen you mention the concept of zero preventable deaths a lot. You may have coined that phrase. I'm not sure.
I did not. No, that came out of a 2016 study at the National Academies of Science and Engineering and Medicine that coined the term zero preventable deaths.
Well, I did see your TED Talk on it.
Oh, great.
But awesome. I think we talk about a lot of, we're talking about TXA, blood transfusions. I still see a lot of shitty basic trauma care. Mm-hmm. And I think that, all of this new stuff, all of this stuff is sexy, but we should probably spend a lot more time talking about just good old-fashioned hemorrhage control.
Well, not to blow smoke up Andy's ass, but the probably one of the most amazing things for me to watch was the study from the Ranger Regiment with the zero preventable deaths in combat. Mm-hmm. And essentially what I got from the study was we did nothing cool. We did nothing sexy. The only thing we did was the basics done right every single time. And that was what translated into increased survival. Now, you can probably speak a lot better than than I can. That's kind of what I extrapolated from that in a rigorous PI process.
I think what made an impact within the regiment was the command influence, command directed that you will do this. So I don't know if we have that. From the DoD perspective, you don't have as much commanders saying this is going to be part of our regular training as much as we did in the Ranger Regiment. And we do see commanders that go out that once they're in the regiment and try to implement that. But it's for some reason, whatever, not as successful. It's just part of the culture there that you are going to learn how to perform these tasks in order to save lives. And part of it is kind of doing some really cool stuff, but a lot of it was just that basic hemorrhage control concept. So learn how to apply a tourniquet, do it quickly, do it the right way, and if for some reason it doesn't even put on, we end up taking it off. And there were a lot of tourniquets that I did take off in combat that didn't necessarily need to be applied. But at the same time, in the care under fire situation, I don't necessarily get too concerned about if a tourniquet needs to go on, yes or no. Other than if you taking the time to apply a tourniquet in a care under fire situation is going to take time, and you're exposed to the enemy. So make sure that I'd like to see them ensure that it's the right patient that needs a tourniquet. From a surveillance setting, I don't know if we have the influence within EMS, these different services say you are going to learn how to do this the right way. Just like we did in Ranger Regiment, you're going to be a master of being able to apply a tourniquet or to pack a wound. And I don't think we're there yet. I think we have this rapid implementation of these hemorrhage control devices without truly understanding either when to apply them or how to apply them.
I've seen quite a bit of that, and it's so locally dependent on medical directors and even just independent providers, and there's no real source of consistency across the country saying, "Hey, these are the devices you should look into," or this is the type of training. There's no real standardized sort of curricula even to begin to lay the foundation for that training. In my experience, at least, if you do look for it, you go to an outside source like the DoD. So you're right. There's no real civilian directive aside from initiatives like Stop the Bleed to say, hey, hemorrhage control is something you should probably be good at, and then here's some extra resources to look into.
Yeah, I've never even seen how they would even implement things like tourniquets in some of these services. And obviously that was still in the military when a lot of these things were implemented. And now coming out, I see some of the poor practices that do happen. And now we're fighting an uphill battle trying to correct that with a lot of people. There's a lot of, quote unquote, subject matter experts out there that try to tell people that they know how to do this and that, when in reality, there are very few real subject matter experts on hemorrhage control. There's people like, Dr. John Craig, who is the expert on tourniquets.
Mm-hmm.
I am moderately informed about tourniquets, I feel, and but that keeps me continuing to read and learn and understand things. And I think that we end up encountering a lot of very proud people that insist that they know what they're doing.
Absolutely. Now, if you were to speak to one of these services and they said, Andy, we want to learn how to get proficient at controlling hemorrhage, what tourniquet should we select? Which one would you tell them to get?
I would simply stick with, what is offered, been recommended by the Committee on Combat Casualty Care. Honestly, I don't see why the EMT isn't used more often in EMS. It's reusable. It has a much better safety profile, better efficacy than the other two recommended windlass tourniquets. And, we don't use it in the DoD for care under fire or at the point of injury, because the bladder could get ripped, right? Mm-hmm. or punctured. EMS, for the most part, doesn't have that issue, right? You should be able to apply EMT or a bladder type tourniquet without significant problems. So I don't see why they're not using that more often. It's more expensive, but again, it's reusable.
I just had to Google a picture of it.
It's like a blood pressure. It's basically a BP cuff with a clamp on it, more or less. It's not a very eloquent description of it, but
yeah. So it's about a 3-inch wide bladder that. It's a very long. It's probably. I'd have to look it up. I have one, but it's a very long tube basically that has a clamp that you clamp it and then you kind of just blow up the bladder, and it circumferentially it blows up and applies pressure to the limb versus one like a BP cuff that obviously the bladder is only so long, it probably isn't going to go circumferential around the extremity. And we've talked about this elsewhere that we are currently doing a tourniquet review on the committee, and so we certainly expect there to be more recommendations to come out, and certainly I can't speak to which ones may make it or are looking better than the others, but I will say that we should probably see some changes coming up soon, and I always just go with what the committee recommends, and being part of this process, it is very rigorous and very serious and very time consuming. And it's not something taken lightly. There is zero financial incentive by anyone to promote one over the other. It's simply about taking the data and looking at the most efficient or effective tourniquets and which ones are most likely going to be able to control hemorrhage, but then also be able to teach other people who don't do this every day how to control hemorrhage with that tourniquet.
Which is a really interesting point, because I was about to ask, what is it, a lot of bench testing, or is it any sort of animal lab practical sort of thing, or what are you guys looking for?
So we don't. So the committee doesn't do any actual testing, right? There are members that do testing, that do publish a lot of studies, and that's fantastic. But mostly, all the committee does is really produce clinical practice guidelines. That's all they are. So they review the data available, and they try to establish best practices and establish those guidelines and protocols that help, that are supported the most. And that's really what it is. It's about providing some evidence-based guidelines.
Okay.
And that's Yeah, so there's no testing involved. It's all taking a bunch of, it's like doing a systematic review or a literature review and looking at all the different things and say, okay, here's what we have on this and this and this, and here's what we have. And there is a consensus, or at least, people have to agree that this is probably what is going to be the best. So it's not like you can take something like, I don't know, let's talk about, hypothermia. I want to even change from tourniquet. So let's take something like a hypothermia. If we look at the data and we say, well, that we have a wool blanket, or we have, the HPMK and something else. Well, the data kind of suggests that maybe a wool blanket doesn't really do much. So, we have to get most people are going to go, okay, yeah, probably doesn't do much. So we probably shouldn't necessarily recommend to use a wool blanket. But here we have the HPMK. I got it's a commercial product, but it appears to probably be the best out there. So everyone probably agrees for the most part that that's the best way to go. So you have the majority of people agreeing that that's probably the best thing to do. And that's how you develop the guidelines. And this is no different than anything else that you may see in development of guidelines, right? I mean, it's not like other people out there just magically come up with some sort of different way of assessing evidence and then putting it into practice into different protocols and guidelines. It's usually kind of have to, use your judgment based upon what the evidence says and make a recommendation.
Absolutely. So could you kind of speak to the role of calcium in the pathogenesis of traumatic coagulopathy? Because we know that most of the clotting factors that we want are all calcium dependent. And there's some data that I cannot necessarily point you to the exact one of hypocalcemic patients upon initial admission to trauma centers, suggesting that if you present with a coagulopathy of trauma, you might empirically be hypocalcemic or close to, not just associated with blood transfusions, which is the classic incidence.
Well, I think most patients that when we talk about this, these are coming from massive transfusion patients. And so I don't know if we know that, is it calcium consumption by, coagulation and hemorrhagic shock, or is it due to blood product administration? I think the majority probably ends up being due to blood product administration that we see the hypocalcemia. But there is plenty of data that suggests that if you are hypocalcemic, there is a increased chance of mortality if you are a trauma patient. So giving calcium should happen earlier than what we're doing right now. Typically, it's given after every 4 units. But myself and others out there have been promoting, hey, why not give it after the first unit of blood? I don't think there's necessarily harm with giving 1 to 2 grams of calcium or 6 grams of gluconate to a trauma patient who clearly is either in hemorrhagic shock or has been resuscitated or is on the verge of hemorrhagic shock. So I think it's important that we get it out there and we start administering it. There's a couple of different studies out there, and I know they're trying to collect some data right now within the DoD, and it's kind of the hot topic right now, I think, is calcium. And so I think we'll probably see some good information come out. I've really seen it in like 3 different studies where it talks about hypocalcemia in trauma patients. And again, it's usually about receiving a massive transfusion.
I would be interested to see if they are hypocalcemic at baseline prior to transfusion.
Yeah, and the problem is the more blood we start pushing in the pre-hospital setting,
it'll be more difficult to discern that. Which I'm cool with. Like if that's a problem we have because we're getting blood, further out of the hospital, that's all right.
Yeah,
I can leave that question there.
But in the EMS, there isn't really a big reason why you couldn't draw blood first, right? Because that's kind of a standard thing to do in EMS. Again, a lot of my stuff, even though I'm I feel deeply involved in civilian medicine at this point, still a lot of my thought processes go back to military medicine, the point of injury care, and how difficult that would be to do that in that setting. There's also there is mortality associated with hypercalcemia in trauma patients. So is it something we also need to watch for? Is maybe not, yes, giving calcium probably needed, but then after that, how much do you give? And I think that's where we probably need to come a little bit closer when it comes to resuscitating to a certain point, and that includes administration of calcium.
Yeah, we listened to a really good PJ Med podcast where they discuss the role of calcium, and they were going to evaluate their protocols to allow them to administer calcium, even if they don't have blood products, just to get ahead of the curve.
So I think it was empiric.
Yeah, empirically.
Yeah, and I'm actually probably okay with that. It's just that I think we're getting a little, putting the cart a little before the horse. If why are you pushing so hard to get calcium out there if you can? Where's your blood? And I love Steve Rush. He is a very good friend and mentor, and I believe he's probably doing the right thing. And I support that his decision to do that. It's kind of like one of those things, like, where are you ever going to be you got to kind of look at, am I going to be in a situation where maybe I don't have blood right now, but I have calcium? I'm sure there is, right? Mm-hmm. So if you're stuck in this austere environment and maybe you've used up your blood and now you have another casualty, and maybe you collect some fresh whole blood, I can go ahead and administer this guy calcium.
I think that's kind of what they were going towards.
Yeah, and that's what, I suspect so, yeah.
There's a kind of prevailing attitude in civilian EMS, and even to an extent some of the fellow combat medics that I know and have worked with, that trauma is kind of easy. Do you agree with that, or do you think it's something that should be paid more proper credence? Because I think there's this notion that you go out, you take PH-TLS, and now you know just about all you need to know about trauma.
Well, I think people who consider trauma easy probably are limited to protocols of tourniquets and pasta water. Mm-hmm. For those that, trauma is critical care medicine and requires, I think, very detailed sort of approach to catering, your treatments towards this specific patient. I get it. If you're hemorrhagic shock, you need blood. But then where do we continue? Like, you just don't keep slamming stuff. This isn't 1995 and we're pushing 2 liters just because we can. We need to tailor our approach. Like, hey, is it time to give calcium? Let's take a look in here. At our levels there. Hey, when was the patient injured? Should we give them PXA now, or should we maybe wait until they get to the hospital? So it takes a lot of critical thinking to kind of wrap your head around what can happen to these patients as they go through this system from when they were injured to maybe when do they get the OR. So do I need to intubate? Well, post-intubation hypotension and RSI in the pre-hospital setting, hemorrhagic shock, there's an absolute connection between that and mortality. So, you're going to be a cowboy and just be like, I'm just going to RSI, or is it someone who truly needs it? Because there are times when patients clearly need to be RSI'd and to get a tube. And you have to think about these processes and what you're doing to your patient, because your patient doesn't have normal physiology at this point. Your patient has disrupted physiologic processes going on, and you have to think about that. So if you're stuck to just putting on a tourniquet, trauma's easy. But if you have the whole critical care package going with you, trauma can be very difficult, and you have to understand what's happening at the cellular level with these patients.
Other than the obvious logistical obstacles, what do you foresee being the biggest impedance to getting blood into the hands of more quote unquote regular guy EMS providers?
And I'd kind of like to know, to add on to that, like, who needs blood? Like, which EMS agencies would be best suited for trying to get whole blood or blood, period, really? Or
just, and honestly, just even plasma.
Yeah.
I'd be okay with a blood product that isn't pasta water.
You clearly can't put whole blood on every ambulance, and that's an issue. The biggest issues right now overall, I think, with pre-hospital whole blood is waste and the associated cost with it. If you look down at STRAC in San Antonio, they have a certain waste percentage that is acceptable with like component therapy, and right now I think with their whole blood stuff, they're wasting a significant more of the whole blood. So we had to figure a way out, right? I think the biggest issue is that, and how to solve that is to get more hospitals and services involved. So then think about it outside of trauma. So people like postpartum hemorrhage and GI bleeds, those sort of patients, anyone who is clearly just in hemorrhagic shock should maybe be receiving whole blood. And so you can push this blood out to these, maybe outlying hospitals that don't necessarily have, they're going to be transferring patients to, maybe the trauma centers and such, or bigger medical centers. And so you put it out there with all the other agencies. And so you develop this sort of rotating system of whole blood. I think that will help reduce some of the waste issues. The cost, I think there's always going to be room for component therapy, always in medicine. There's absolutely a need for it. So I don't know how much a significant impact it will make on the blood banks by trying to support this whole blood initiative. And when you can't use whole blood, then I think plasma is the way to go. So you got like thawed plasma, but I think what's going to make a bigger impact is the freeze-dried plasma.
I'm eagerly awaiting the civilian translation of freeze-dried plasma.
Right, and I think as we see that the companies are right now, I think working on developing these clinical studies with these different EMS agencies, I think that will really kind of make a huge impact. So now I can have, say I'm a very small service out in the middle of nowhere that does, 300 runs a year or whatever. Well, maybe I only need to put the FDP maybe in the supervisor vehicle, but it's got 2 years it can sit there. Versus, the other, like a cold stored and cold chain type blood products. So that's the way to go, man. I truly believe that freeze-dried plasma is going to make a huge impact.
And that's what I'm looking forward to as well. I think Denver had it right with the combat trial and trying to thaw it, but I think there's also some logistical concerns that go along with that. And from the military side of the house, looking at some of the stuff from SF and their success with freeze-dried plasma, and then going back to the historical side and looking at the benefit that was had in conflicts past, I think it solves a lot of problems. If it doesn't solve them completely, at least makes them more reconcilable.
Yeah, I think so. And you put whole blood. I think if you look at down at Houston and what Eric Bank and Ren Neely are doing down there, and down in San Antonio, to where you're putting it on these, these supervisor vehicles or whomever is responding, doesn't have to be put on every ambulance, but it's dispersed enough out within the service that someone can respond quickly with the blood to the scene and to get it started. I think that's where it's going to go, and it's hard to probably not find a helicopter service that couldn't carry whole blood. I think they'll probably stay busy enough for the most part. Obviously, there are some services out there that are a little bit slower, but a lot of helicopters could probably stand to carry whole blood.
One of the major sort of rebuttals I've heard to employing the use of tourniquets in hemostatic devices is I've never seen someone bleed that badly. Just time and time and time again. Now, is that kind of dismissal, an actual low incidence of injury, or is it the failure to recognize severity?
The data suggests that about up to 20% of the trauma patients out there, the deaths from trauma, are due to bleeding. Certainly a significant portion of those, or some portion of that, is due to either limb, extremity, junctional type bleeding. So it happens. So we're not doing something right, and I don't know if it's people don't recognize. I think there is a problem with people not recognizing when to put on a tourniquet or what is an arterial hemorrhage versus maybe what is venous bleeding. I think that's an issue, but I think that goes back to earlier how we were kind of talking about. How do you implement these programs and say you're going to become experts in this? And part of being experts in this is kind of understanding what these, what a life-threatening hemorrhage looks like and how to address it.
Okay.
So
I've actually seen life-threatening hemorrhage from a scalp lac, which has has credence in the literature.
Life-threatening hemorrhage is it happens. I mean, for the most part, it's just about applying pressure, right? But a lot of people don't even understand how to apply pressure, I think, appropriately, or they get, I don't know what it is, but they get thinking they need to do other things like start IVs and such, instead of doing the simple basic maneuvers that can save a life.
I think it's once again, it's a byproduct of kind of generational knowledge translation, but also it seems kind of counterintuitive to a rhythm or to a very dead set routine of doing things the same patient, same time, over and over and over again, to stop everything completely and just hold pressure. Because I think when you're used to starting IVO2 monitor and do that for a career, and now you're like, okay, just hold pressure on this patient until it stops, do nothing else. I think it gets kind of hard to rewire that neural network, or that at least that force of habit. But at least when you sit down and educate people who are willing to learn, then it tends to come together. So what are some common trauma management pitfalls you've seen both on the civilian side and on the military side of the house? And is there any common ground between the two?
What we talked about earlier a little bit was things like hypothermia prevention sticks out for both military and civilian pre-hospital care. I don't think there's enough emphasis put on that. I also, as we've kind of talked about the entire time, is this idea of that skills need to be done and not necessarily understand the fundamentals. And I think that goes across the board for both sides. Years ago, they took out starting IVs for combat lifesavers, and it was like, well, no one wants to go do combat lifesavers more because they can't start IVs. Well, what are you really going to get out of starting an IV? I get it. You can stick a needle in someone's arm. Well, if you want to go do that, go be a medic. And even then, it's not done that often. And for a lot of patients, now you go to EMS, obviously you do it a lot. But I think we tend to probably get in our brains this approach, as I think you kind of talked about, that this is the IVO2 monitor sort of concept. And instead of, maybe we need to change that dynamic a little bit and on how we approach things like trauma medicine. It isn't IVO2 monitor for these patients. I still think the March algorithm is probably the best approach. And that really kind of explains and addresses the issues in a manner that goes from the highest mortality to more the lower mortality sort of issues, right? So getting people to understand that early hemorrhage control with whatever technique you want to use. You want to use direct pressure tourniquets, pressure dressing, structural tourniquets, whatever, do it. And then moving on down the line of different airways and airways really kind of I think unique to the military. I don't think you see a lot of significant airway issues in civilian medicine like you do in the military. And what I mean by that is we talk about doing crikes a lot in military medicine, and that's simply because of the number of maxillofacial trauma injuries that are seen in such a little bit higher prevalence than what you see in civilian medicine. So that's why it's kind of like it's kind of early on in the algorithm to do.
Yeah, the mechanism is completely different. If you're routinely dealing with blast injury, civilian side, you should probably move.
Right. Right. And then so you go to respiration, and it's just a great algorithm, I think, to assess and treat a trauma patient. It kind of does the assessment / treatment along the way, versus I think the old way that EMS has been doing it for a long time. Of let's talk about airways, PSI seems safe,
the old NREMT jazz hands.
So and so I think that's part of the problem. Maybe we need to change the culture and a little bit, but also change the way we treat trauma care and get away from the older methods and maybe try to adopt something that's a little bit more evidence-based.
Absolutely.
But I think it's a military problem too. Don't get me wrong. We still have a significant amount of potentially survivable deaths within the DoD. And some of that has to do with, again, I think less command emphasis on training, getting the medics trained, and getting the infantrymen trained, or the cav people trained. I came from infantry, so that whole cavalry thing gets kind of lost on me. Yeah, I mean, that's what they need to do. So DOD is, I think, more command emphasis. EMS, I think it's more of just changing the education paradigm.
So starting with the changing the education paradigm at the kind of individual provider and agency level, do you think that a zero preventable death civilian trauma system can be sort of realized using almost like the quasi JTS? Because as I understand it right now, there's a really fragmented network of civilian level ones and whose recommendation you should follow and this and that. And there's no real cohesion like the military has a benefit of largely getting of a directed joint trauma system and a standardized set of CPGs.
Well, if you look at, so in that 2016 study, it kind of talked about developing these military civilian systems that work together, so we can kind of take the both of best world of both of the best of each and kind of adapt it. So I think that's kind of maybe the way, looking towards that document and how we can further develop these military civilian partnerships to kind of use and adapt the best of those both those systems to make it better for our patients. I think the goal of zero preventable deaths, and why I talk about it a lot, and say, hey, we can do this. I'm also kind of I'm a realist and understand that I don't think there's ever going to be a way to completely eliminate something, potentially spiteful death. And it's just a reality. But I do believe we should put forth a significant effort into trying to eliminate as much as possible.
So I couldn't have said it any better than that. Now, say I'm a new or relatively new BLS or ALS, take your pick, provider on just a regular ground ambulance. What are the highest yield things I can do to improve my trauma care?
I think understand the March algorithm. I know I keep pointing to that, but it's just a simple and direct approach that it's kind of like ATLS. I mean, so surgeons do ATLS, and it's kind of that algorithmic sort of approach that just helps them along the way. And I think it's a great approach. Yeah, I mean, I think it's the way. I think getting away from the current approach and adopting a more logical trauma approach, and I think we could civilian medicine can probably take something from ATLS, and maybe they have, but maybe they need to kind of relook it. And I don't think people should just be going out there and taking Teachable C because they can. I think Teachable C is specific towards military.
Dear God, thank you for saying that. That is, that's a personal thing with me. It's just that's a soapbox.
Yeah. I think it's, even TECC is offered for maybe more civilian tactical stuff. But man, I think that, like I said, I think the March algorithm is just fantastic. It just outlines everything you need to do. So you can take all the phases of care and everything. Overall, it's still the same approach each time, and you can adapt it towards each area of medicine, whether military or civilian.
I think that's what makes that kind of algorithmic approach so beautiful and so effective, is that you can take it tells you what to look for, and it also tells you how to treat it in the same breath, and in an order that makes sense and effectively reduces mortality as much as we possibly can. Yeah.
I heard someone talk about one time in some place that said, only inexperienced people use things like ATLS and algorithms. I'm like, no, they don't.
That's patently false, because
every surgeon that you've seen that I've worked with has a standard approach that's done each and every time on every single patient. And that's how, you become better and you don't miss things, is by doing the same thing over and over and over again.
And almost to the point of neuroticism with some of the, had the opportunity to do a little bit of training in Chicago and interact with some of the surgeons up there. And you're exactly correct. The same way every single time for 20 or 30 years.
Yeah. And they don't miss things. And again, we're all human, and we all make mistakes. But overall, the approach is so standardized that it makes it almost impossible to miss stuff.
So would you like to tell us about National Stop the Bleed Month?
Yeah. So, yeah, National Stop the Bleed Month. For those that don't know, May is now National Stop the Bleed Month. And essentially what we did is a group of guys, all veterans, we all kind of came together and kind of said that, Stop the Bleed program is fantastic. And, we're teaching bystanders how to, save lives. And, it's kind of mimicking what we did in the military. But we didn't see it being as effective as we thought it could be. So we last year in 2018 did National Stop the Bleed Day. And again, we don't run Stop the Bleed. We're not even affiliated associated with them per se. We have a good working relationship with the American College of Surgeons and the Stop the Bleed campaign and bleeding control, but we are not them, right? And I like to make that clear, that all we are a group of people that are calling more attention to that program and trying to get not only more people in the seats, but also try to find people to go teach. So finding EMS, I think this is EMS's role. Is EMS needs to be out there going and teaching in their community about how to be able to control hemorrhage in these situations and potentially save a life, because it's not gonna be an active shooter. I'm sick of hearing about active shooter stop the bleed stuff. It does happen, and that's a terrible tragedy. But the most likely scenario is going to be that it's going to be a home accident or a car accident or something at work, some sort of accident that's going to cause these traumatic injuries that could potentially, someone may die. So that's what we need to train people to do, is recognize what is a significant injury that requires a tourniquet or, aggressive hemorrhage control, and then how to do it and be prepared to be able to take care of that. And that is either one, carrying something on you, or, advocating to get something put in your place of work, or, maybe carrying something in your car or whatever. Or working through your elected officials to get them put in public places, these public access hemorrhage control kits. So I think that's kind of what we do, is simply kind of bring more appreciation for it and try to bring more people into the fold, both students and instructors, and just bring more light to it. So that's what we do, and we're trying to do it this year. We're doing the entire month of May. Since last year, just doing the one day was not sufficient. So we actually expanded it last year out to be about 2 weeks. So this year, the entire month of May, with these kind of ceremonial day being on May 23rd during EMS week.
So say I'm a interested EMS provider or agency, what can I do to register instructors and start holding Stop the Bleed classes? So
if you go to bleedingcontrol.org, there is a place site that says for instructors and how to register, and it's like you click on the link and you kind of fill out the information there, and it takes sometimes up to like a few weeks to be able to get approved to teach the courses. But after that, man, it's basically you're registering your courses and teaching as many people as you can on how to do this stuff. I don't think the college is even requiring people to turn in all their sheets and everything saying how many people they train. They actually kind of close everything out and say these are the numbers I trained, but it's not like you have to turn in like sheets of people like, hey, here's the names and contacts and all that stuff. You can make your own. You can make your own certificates and everything, so it doesn't require any sort of significant effort outside of simply registering and then kind of putting on these courses.
They make it very easy to become an instructor and teach the class, and I think that's how they should do with hands-only CPR. Like, we've created our own local hands-only CPR class, so we don't have to teach a full AHA class every time.
Also, your if you want to plug it, your Raptor course in September.
Oh yeah, so we do teach pre-hospital. The only pre-hospital REBOA course in the United States is we do it in conjunction with a couple different people and a couple different organizations. But we do have it in September 9th and 10th in Houston, Texas, down at Herman Hospital. And I'm the assistant course director. It's Zaf Kasim. incredibly bright and smart and fantastic emergency medicine physician that works out in Philadelphia. He's the actual course director, and of course, so we have people like Dr. John Holcomb, Dr. Jody Bowes, and some others on there. But certainly those kind of the big people that have been very heavy into kind of creating this course and making it available. So what we do is we basically teach you about how to implement whole blood, teach you about whole blood. Then we talk to you about how to implement Roboa and how to do Roboa. And it's over a day and a half course, or day and a half long course.
All right. Well, it's been an honor.
Thank you very much. This has been excellent.
Yeah, it's been a pleasure.
Should we tell our listeners they can hit you up on social media if they have any questions, or?
Yeah, they can hit me up on social media if they want.
I'm sure they see you on social media.
Andrew D. Fisher. Yeah, I have somewhat of a presence. Andrew D. Fisher, and then Instagram's Fisher81. Same on Twitter. I'll put up a bunch of studies and stuff on Instagram.
Yeah, it's actually pretty awesome.
All right, everybody. We really hope that you enjoyed that podcast. Please share it with your friends. Hit us up on social media. You can find us. Our handle is @CurbToBed, and we are on Twitter, Instagram, and Facebook. Let us know if you have any questions. Thanks.